Estrogen and progesterone are hormones that have multiple actions. They promote female maturation and they help regulate the ongoing activity of female reproductive organs. In addition, they also affect bone mineralization and lipid metabolism. Estrogens are responsible for the maturation of sex organs, but also for the stimulation of the development of the secondary female sex characteristics, which would include development of the breast, skin, bone development, and distribution of body fat and hair. Progesterone helps create optimal conditions for pregnancy in the endometrium just after ovulation, and it also helps promote the start of menses in the absence of the fertilized ovum. So both of these are very responsible and play different roles at various times of the female menstruation cycle. Both estrogen and progesterone can be used and are used in preventing pregnancy, but they can be used alone for different reasons. Estrogen is rarely used alone in women that still have their uterus, and the reason for that is because it greatly increases the risk of endometrial cancer. When it's paired up with progesterone, that risk goes down significantly. So usually when you see an oral contraceptive, you'll see estrogen and progesterone together. Occasionally you can, like the mini pill is just progesterone, and that would be for women who are nursing primarily, that want to prevent future pregnancies, because estrogen can inhibit the production of a mom's milk supply. Estrogen might be used alone in a woman that no longer has her uterus for the management of menopausal symptoms, primarily hot flashes. Estrogen helps greatly with that. I do want you to keep in mind, anytime a woman is taking either one of these, really, to be looking for common adverse effects. I think they're associated more with estrogen, but progesterone can affect them as well. But there is a high risk of hypertension, very high risk of blood clotting with women that are taking estrogen supplements, birth control pills. You always want to do a lot of patient education related to assessing for clots. They can cause edema, nausea, vomiting, diarrhea. Those generally will subside with continued use and can be eliminated if you educate the mom to take these pills with food. Generally, even at night, it can help alleviate that. Breakthrough uterine bleeding can be very, very common and should not be a huge cause for alarm, unless the amount of bleeding has significantly changed, say for the heavier. It's very common when women are taking birth control to see their periods lighten over time. I would caution a woman, if she's having breakthrough bleeding, to eliminate, to evaluate, to assess, to make sure she's not pregnant. Some other things that they might notice is facial skin discoloration, tender breasts, fluid retention, and headaches. Estrogen specifically, you might want to educate your mom to stay out of the sun. That can increase the risk of the facial discoloration. I do want to point out also that estrogen is often used in the treatment of prostate cancer in men, as it can slow or inhibit the growth of the tumor. Progesterone helps prepare the endometrium for the egg implantation, and like I said, promotes the start of menses. It's used in birth control pills, like I said, in the mini pill alone, oral contraceptive, very common to have it paired up with estrogen. But you could also see it in IM injections such as Depo-Provera. That's an injection that's a slow release of the progesterone over time. It's good for 90 days. So every 3 months, the woman would need to go into the office and have another progesterone shot to maintain that low risk for pregnancy. I do want to point out too that progesterone has been linked with bone density loss when it's used for long periods of time, but that generally does correct itself with discontinued use. So oral contraceptives are used to prevent pregnancy. They're generally a combination of estrogen and progesterone together that would inhibit ovulation. but you might have a mom that opts to take the mini pill, which is progesterone alone. That she could take while she's nursing because estrogen is known to inhibit the milk supply. They are contraindicated in pregnancy, history of thromboembolic disorders, cerebral vascular disease, coronary occlusion, breast cancer, abnormal liver function, abnormal vaginal bleeding, and smokers over the age of 35. They should be used with precaution in women who are diabetic, have hypertension, cardiac disease, gallbladder problems, epilepsy, and migraine headaches. And also note that women who are having surgery during a time where maybe their mobilization is inhibited, they might be cautioned to stop taking oral contraceptives because of the risk of clotting would be so much higher for them if they can't be up and moving around. So as far as use in pregnancy and lactation, oral contraceptives have no therapeutic role during pregnancy and so therefore are contraindicated, but it's not because it'll hurt the fetus. It will pose no risk of fetal harm. So just really keep that in mind if you have a woman that comes in that's just discovered that she's pregnant, is really, really panicking because she's been on birth control, that you could help alleviate her fears and let her know that it will not have caused any harm to the fetus. When you're educating your female patient about taking oral contraceptives, really caution her to be taking them at the very same time every day and encourage her to take it with food. That will help decrease those the nausea and vomiting symptoms that can be present at the beginning. To have them take that at night, but really stress not missing a dose. Taking it at the same time of day every day can help cement those habits. There are different teaching that you'll want to provide if she does miss a dose, and this is very, very specific to when in the cycle she missed a dose. How many doses did she miss? Things like that. And so for the purpose of this upcoming test, you won't need to know that. But I do really want to stress that you should know that anytime you have a female that's on oral contraceptives tell you that she's missed a dose, that you should be highly encouraging her to use another form of birth control for the remainder of that cycle. Be using condoms, be using foam, use the sponge, use something until her cycle starts back over with a new pack of pills, because she does have an increased risk of becoming pregnant. And we talked about smoking already. Let's talk about the emergency contraception pill, also known as the morning after pill. And this would be is defined as a contraception that's implemented after intercourse. So this would be used for a woman that had sex with unprotected intercourse. Could be the result of an assault or a broken condom, or whatever reason. Morning after, didn't know what I was doing, whatever. Anyway, it's safe and effective, and it's been available for decades, but it really hasn't been marketed specifically for use until recently. So statistics do show that nearly 50% of women ages 15 to 44 years have reported having at least one intended pregnancy. And I'm not going to ask you to raise your hand if that's you, but it was me once. Among teenagers, 88% of pregnancies are unintended. Of the 6 million pregnancies that occur each year, about 3.5 million are accidental. Every year, unintended pregnancies lead to 1.4 million abortions and 1.1 million births that women did not want, at least not yet. And so clearly, if we could get the education out there about the emergency contraception pill, that would significantly reduce those numbers. I think it's important that we know what the emergency contraception is all about. I think it gets a bad rap. I think I've heard it referred to as the abortion pill before. But the definition of a pregnancy is a fertilized egg that implants to the wall. A fertilized egg cannot grow if it's not implanted to a blood supply, right? It's just a fertilized egg. It doesn't do anything else. That's not a pregnancy. It has to attach to the endometrial wall, receive a blood supply to start to grow. This emergency contraception pill prevents that from ever happening. It can either stop the egg from dropping at all if it hasn't yet, or it can stop the endometrial lining from preparing itself, much the same way that regular oral contraception does regularly over time. Let's see, what else do you need to know? It needs to be taken as soon as possible after intercourse, but after 7 days, it's totally ineffective. It's still mostly effective up to 5 days, but it starts to wane after that 72-hour period. So really, if they can take it in the first day, 2, 3, that's optimal there. If you have a woman come in and ask for it, tells you that she's had unprotected sex, the first question you should ask her is, when did you have sex? If it's after 7 days, there's no reason to take it. Okay, so some patient education there. You need to know that it's totally ineffective after 7 days. Write that down somewhere. That might be a question on a test. And then in general, we talked about oral contraceptives do prevent ovulation. A little bit of patient education to go along with oral contraceptives. Like I said, it's better tolerated if taken with food or water. You should be advising your patient to report any hypertension, edema, thromboembolism. Teach her what that would feel like, what to look for signs of clotting. Migraines, depression, breakthrough bleeding. Instruct the patient to take oral contraceptives exactly as ordered and to keep all appointments for follow-up exams. This would be a really good time to teach how to do monthly breast exams, right? Counsel on the importance of using condoms with oral contraception to prevent sexually transmitted diseases. I think it's important to know that the pill won't prevent that at all. You need to educate the patient about making lifestyle changes as recommended, such as engaging in weight-bearing exercises like walking or swimming. This would really help with that bone density decrease problem that you might see with progesterone. Stop smoking. Limit or eliminate alcohol intake. Those measures will all help decrease the occurrence of adverse effects of oral contraception and regular hormonal replacement therapy. Okay, so when we're talking about uterine stimulants here, we're going to focus on 2 main categories, which is the oxytocics, which stimulates contractions, and then the tocolytics, which relaxes the contraction. And we'll focus on 2 major ones there, which would be oxytocin and magnesium. So let's look at oxytocin first. That is a uterine muscle contractor. It is released by the pituitary gland, and it affects mainly the uterus, but also affects the breasts. It is commonly given to manage incomplete or inevitable abortion, controlling postpartum hemorrhage, and to induce labor. So when we're talking about inducing labor, we give it to increase the force, frequency, and duration of uterine contractions. And it really depends on where a woman is in her pregnancy for how the uterine will respond to oxytocin. Depends on the stage of the gestation. So early in pregnancy, uterine sensitivity is pretty low, but as her pregnancy proceeds, the uterus becomes more progressively responsive, and just before term, a really large and abrupt increase in responsiveness will develop. Sensitivity increases over time because the number of oxytocin receptors on uterine smooth muscle increases throughout the pregnancy in preparation. So although smooth muscle increases throughout pregnancy, and it's really low in pregnancy, in early pregnancy, it can still initiate and enhance contractions. So if you had a woman that was earlier on and had started to abort but didn't finish, she would just need a higher level of IV oxytocin to promote those contractions to help that abortion finish itself, if that makes sense to you. There are definitely some contraindications with using oxytocin, which would be using it in a mom where the baby's head is not engaged, favorable fetal position or presentation, fetal distress without evidence of imminent delivery. So this is where if a baby went into distress, but the body, like the cervix hadn't started to soften or something, we wouldn't just go in and start oxytocin. We would probably do a C-section if the baby was in distress. It is not appropriate to use with placenta previa or cord prolapse, and we shouldn't use it with women that have active genital herpes. It also should be used in great caution in women who have had 5 pregnancies or more. And it's because these women are at really, really high risk of having uterine rupture when they're used in these scenarios. We don't want to use oxytocin if you have a mom in labor and her contractions are longer than 60 to 90 seconds, you need to stop that drip, okay? Because there is a really high risk of uterine rupture then too, and harm to the baby. And to combat that, we would keep magnesium close by. So remember, magnesium is our relaxer. We talked about that in our electrolyte lecture. It would do the same thing with the uterine contractions. It should relax that. And so if you hop down to the bottom where we're looking at the tocolytics, magnesium would be our exemplar there. And it's used to prevent labor. So if we're looking at those, tocolytic drugs are used to suppress contraction of uterine smooth muscle. They have only one indication, and that's to delay preterm labor. And generally when we use that, it will only delay the labor for 48 hours. During this time, they might be giving the baby, in drugs to enhance the development of the lungs, things like that. Okay, so let's go back up to oxytocin here and talk about stimulating the milk. I want to really, really stress that oxytocin does not help increase a mother's milk supply. It does not help increase milk supply. It stimulates the milk ejection reflex. And so we're talking a contraction method of action there too, right? The milk is already being, what's the word? The mother is increasing her milk supply by other methods that are hormonally driven, but once the milk's already in the ducts, we need the contraction to pump it through. Does that make sense to you? And that's what oxytocin will do there. Normally this happens when a baby suckles at the breast. That's a hormonal response where the body naturally releases oxytocin for that contraction. But if a mom is struggling with that, we can help her with IV as well. It is commonly given to mothers who have delivered already, and that is to help the uterine contractions, to help expel the placenta, for instance. It will help stop or prevent postpartum hemorrhaging, very commonly given there. It sometimes is given in labor if a mom is already in labor, but it's not, her contractions aren't strong enough. But we use it very, very cautiously in women who are already in labor. Just because we can, if the intensity of the force of contractions gets too strong, it can cause uterine damage, laceration, rupture, trauma to the infant. So some of the things that we want to know when we're giving oxytocin: we want to frequently assess baseline vital signs, blood pressure, fetal heart rate. Constantly monitor frequency, duration, and strength of contractions. Stop the infusion. Notify the physician if the resting uterine pressure is above 15 to 20 milligrams of mercury, or if those contractions are lasting longer than 60 to 90 seconds. Or if an alteration in fetal heart rhythm or rate occurs. Some side effects of it: it might cause tachycardia, it might cause some premature ventricular contractions, hypotension, nausea, vomiting, water intoxication. So oxytocin can mimic or is similar in structure to antidiuretic hormone, which acts on the kidney, right, to decrease excretion of water. And so in these laboring moms, we could see a retention of water, and you need to be assessing for that to make sure that we aren't causing some renal failure while the moms are on this. I think that's it for that. I do want you to remember the stimulate the milk ejection reflex. I think there's a question on your test that many of you will get that might kind of trick you up if you're not really paying attention to what that question is asking. So remember, it stimulates the milk ejection reflex. It does not increase. So if you have a question that one of your answers is it increases the milk supply, look for a better answer. Okay, there's my hint to you there. Look for a better answer. So when we're talking about male reproduction, androgens are secreted by the testes, and it produces testosterone that's primarily responsible for the male libido. It's also responsible for puberty in males that would affect the enlargement of the scrotum and the testes, and the development of hair on the trunk, arms, legs. It stimulates growth of bone very rapidly for men in their skeletal muscle, which causes their height and weight to increase. It accelerates or it promotes the deepening of the voice because the larynx enlarges. It's also necessary for the production of sperm in males. Females, I do want to point out that women do produce a small amount of testosterone as well that does affect our libido and the promotion of clitoral growth. In males, it also is responsible to promote the synthesis of erythropoietin, which remember is in the bone marrow. So when we're looking at the red blood cells, that is why men have higher hematocrit levels than women do, is because of their testosterone levels that they have, which also puts them at risk of thrombosis. Okay, so the higher the erythropoietin effects from testosterone can result in an increased risk for thrombosis leading to stroke, myocardial infarction, and subsequent death. So just keep that in mind. I don't think we tie that in with testosterone as much as we maybe should. So in keeping with talking about androgen therapy, we might use that in females that have cancers that are estrogen fed. They might be prescribed it wouldn't be a large dose, but they might be prescribed testosterone therapy to help slow the growth of those estrogen fed cancers. But if we flip that and talk about estrogen therapy in males, because males do produce a small level of estrogen in their bodies as well. And we do use estrogen therapy in males for the treatment of prostate cancer because it suppresses the secretion of the androgens that are feeding those cancer cells. So you might have some questions coming up about why a male might receive estrogen or why a female might receive testosterone related to cancer. So keep that in mind, okay? When we talk about testosterone, when we talk about testosterone creams, and this is way at the bottom, but I just want to jump ahead since we're talking about testosterone, that we really want to keep that away from women of childbearing years because it can affect the development of any female fetuses in the womb, and it would manifest as abnormal genital development. A very enlarged clitoris. It's something that might look like the development of testes in a female that would be irreversible. Okay, let's talk about Viagra, sildenafil, which is a vasodilator, and it's contraindicated with the use of nitroglycerin. So when you are talking scenarios, you're interviewing a new male patient and you're going through their medication list, or maybe they've come to your clinic or something for help with erectile dysfunction, one of the first questions you need to ask is, are they taking any nitrates like nitroglycerin? Or vice versa. If you've got a patient that comes in with chest pain, one of the first things you're going to want to do is assess what medications they are on and see if they're on a vasodilator for erectile dysfunction. And it's really important that you know that, because say you've got a patient that's on nitroglycerin for chest pain, that's a vasodilator that helps more blood get to the heart and decreases the pressure on the heart, decreasing the need for oxygen in the heart muscles, which alleviates the chest pain. Well, if we're doing that, then we go give them another vasodilator, because like Viagra is a vasodilator that shunts the blood down to the penile area, right? If we do that, we can cause very serious levels of hypotension in these male patients that could be life-threatening. So these drugs should never, never, never be given at the same time. You should have a pretty good window of time between administration, which would be 24 hours. So Viagra should never be used within 24 hours of using a nitrate, such as nitroglycerin. Other medications that they take for high blood pressure or whatnot could affect the use of Viagra as well, such as an alpha blocker or some of the lisinopril kind of medications as well. Many medications can affect sexual function or lower sperm count, and we'll talk about that in further on in the semester. Beta blockers comes to mind. Could inhibit, cause erectile dysfunction. Some things that you want to know with these men is to be assessing their weight and vital signs, heart rate, blood pressure, lab values, serum cholesterol, everything on that list. Go through there. Things that you'd want to be assessing with a patient that is taking a vasodilator. I do want to, here at the very, very end, talk just for a minute, or really highly encourage you to brush up on anticholinergics, cholinergics, sympathetic response, parasympathetic response. Go back to your anatomy and physiology. I don't know if you touched on it in Pharm 1 or not, but you may have a question that talks about an anticholinergic effect and what you need to teach the patient or what you need to report to the doctor. And some of these medications that we give, say for like prostate or BPH problems, could cause an anticholinergic effect. And one of the biggest ones that you would see there that's related to the GU system would be urinary retention. But just go through those lists of what an anticholinergic response would be, so that you know what some of these medications might do. Okay, here's just a few extra bullet points about Viagra patient education that I should have mentioned. It's best if it's taken 1 hour before sexual activity. It should be noted that Viagra will not cause an erection if there is not any sexual stimulation happening. Again, don't take it with any nitrates. I'm sure you have all seen the TV commercial that says, please report any erections lasting longer than 4 hours. I'll never forget one of the times that, it's been several years, but my probably then 11 or 12-year-old son had walked past when they had mentioned that on TV, and he just stopped dead in his tracks and laughed and said, do you think? Anyway, that can cause permanent local tissue damage to the penile area that would result in permanent erectile dysfunction, and it needs to be taken care of very, very quickly with medications and flushing of the tissues and the the vascular system down there is a better way to say it. So And then again, always teach that if your patient is taking these and they're experiencing any signs of hypotension, headache, blurred vision, these are all constriction problems or lack of oxygen because of the vascular problems, that they need to report that immediately.